Okay, let's do this. I'm live streaming on Facebook in the Thriving Urology Practice Facebook group and also to YouTube. As always, if you have any comments or questions, please feel free to leave them below. Today, I'm going to talk about some of the questions posed by some members in the Thriving Urology Practice Facebook group talking about Modifier 25 when it comes to BPH and cystoscopy, as well as something that CIGNA started doing again or is attempting to do again after postponing this effort back in 2022. Lastly, I want to talk about observation in the operating room by someone in the business office. For those of you who don't know me or who have just joined the Thriving Urology Practice Facebook group, my name is John Lin. I'm a urologist here at Sunrise Urology in Gilbert, Arizona. Also, your humble host of the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for everyone's benefit. Let's get into it. All right. First question or first comment was made by Dr. Shakuri, who said, discussion for billing gurus. I'm definitely not one of those. I just play one on YouTube and Facebook. When you see a patient with BPH with obstruction or lower urinary tract symptoms, ICD 1040.1, and their symptoms either progress or they decide on a procedural intervention, which is what urologists do, right? An office cystoscopy is performed, something that I did multiple times today in the office. After the cystoscopy and transrectal ultrasound, which I performed multiple times today in the office, and during the same visit, you document that you separately sat down with the patient and discussed the findings of the cystoscopy and ultrasound and reviewed all treatment options, including the risks, benefits, alternatives, prognosis without treatment, etc. The diagnosis remains N40.1. The patient elects to schedule a surgery, such as a TURP, UroLift, aquablation, simple prostatectomy, robotic-assisted prostatectomy, whole lip, whatever. Is it still a case of 52000, which is the code for CPT code for cystoscopy, plus 9921X, which is an established patient code, E&M visit code, with Modifier 25? There's some disagreements among the billing folks in my neck of the woods. Thanks in advance for the collective input of the group. And I think I briefly responded to this in the Thriving Urology Practice Facebook group, where I said there are a ton of videos talking about Modifier 25. You can find them on YouTube. You can find them on in the Thriving Urology Practice Facebook group, where I talk about Modifier 25. So I'm not going to belabor the point too much, other than to say that, number one, medical necessity. What is the medical necessity for this established patient visit? Is there medical necessity? And the simple answer is yes. There's clearly medical necessity to sit the patient down to talk about the treatment options and ultimately deciding on a treatment and then pursuing that treatment and also doing the pre-op work, talking about the consent process, talking about the perioperative course. And so the question is all that work included in the generous global payment of the CPT 52000? Once again, I sound like a broken record. I can't even tell you how many times I've talked about Modifier 25. So, CPT 52,000 for cystoscopy includes the generous payment in CPT 52,000 includes the preoperative workup, the performance of the actual procedure, and all the supplies needed for that procedure, and also telling the patient about what you found during the procedure, and also making sure that patient tolerated the procedure very well, and making sure that the patient is recovered from the procedure, giving him the post-operative instructions, etc. All that is included in the generous global payment for $52,000. What is not included is something that Dr. Shakari mentioned: the implications of the findings, the treatment options of the findings, the ultimate decision to make to decide on a particular surgery, the discussion regarding the perioperative course for that particular new surgery that you decided to do, the informed consent process carried out, all that is not included in a global of 52,000. And I would direct you to whoever you're disputing this discussion, this concept with, your coder, biller in your institution, in your neck of the woods, if you will. I would direct them to the numerous videos in this Facebook group on YouTube. Just search Modifier 25 John Lin on YouTube, and you'll find numerous videos talking about Modifier 25. They should be able to find the clear documentation from CMS, NCCI about Modifier 25 use, the appropriate Modifier 25 use, and not whatever they think is the appropriate Modifier 25 use. You said you sat the patient down. You don't need to set the patient down like I do in a separate room. You can literally have the discussion in the procedure room where you perform the cystoscopy. As long as the work is carried out, clearly medically necessary, it is significant. And here's the thing, separately identifiable. Now, some of your payers may want a separate area where you document this discussion, and I encourage you to do that. However, some electronic health records do not have the ability to do so. I'm very fortunate in that I do have the ability to document my cystoscopy in a separate section in my EHR, but ideally you want to make it simple for the layman, these dumb insurance auditors, to be able to see that this is a separate area where you're doing the documentation. Make it easy for them so when they audit you, they can see that here's all the work that I did for the cystoscopy, and then this is the separate discussion that we carried out that is significant and separately identifiable from the cystoscopy. Make it easy for them so that they can appropriately adjudicate the claim and pay you the Modifier 25 event. So the Modifier 25 goes on the E&M code. Make sure that you do that. So the bottom line is, yes, you can and should, in your situation that you described, Dr. Shikari, bill for an E&M, established E&M visit and a Modifier 25 with the 52000. I think it's definitely appropriate, and you should do it because it seems like you did the work and you documented the work. So make sure you document the work. Anyway, common occurrence when it comes to BPH cystoscopy. And keep in mind, I know you mentioned, Dr. Shikari, that you mentioned N40.1, not once, but twice. You do not need a separate diagnosis for when you use Modifier 25. That is clearly written in CMS guidelines, and I refer your coders and billers to the CMS guideline, where it specifically, literally says that you do not need a separate diagnosis. Okay, let's move on to the latest, the latest shenanigans by CIGNA, and I'm going to look at this letter from CIGNA on March 6th of 2023. Now, they tried to do this about 8 months ago, back in 2022. And they basically said they routinely review their coverage, reimbursement, administrative policies for potential updates. And basically, it's just a bunch of bull regarding why they're doing this. The bottom line is, for any established patient E&M visit, 99212, 213, 214, 215, starting on or after May 25th of 2023, for a CIGNA patient, if you bill an established patient with a Modifier 25, in addition to submitting the claims electronically, in addition to what you already normally do, now you have to submit documentation. So we will require the submission of office notes with claims submitted with evaluation and management CPT codes, as I mentioned just now, and Modifier 25 when a minor procedure is billed. The E&M line will be denied if we do not receive documentation that supports that a significant and separately identifiable service was performed. Denials will include administrative appeal rights, meaning if you disagree, you can appeal. This update is effective, again, on or after May 5th of 2023. And they already updated their documentation, their policy on their website regarding this change. And on their claims and documentation submission, the required office notes must be submitted via the dedicated fax line or to a specific email address. Claims should continue to be submitted electronically and must have the attachment indicator selected. Claims and documentation will also be accepted via mail. So basically 3 ways for you to submit this administrative bull that you now all have to do starting May 25th of 2023. Not only do you have to electronically submit the claim for adjudication, now you have to make sure you include the attachment indicator in that claim and submit office notes documentation to CIGNA to this either a fax number, an 833, a free fax number, or an email or via mail. The email address is modifier25medicalrecords@cigna.com. Will you be submitting this email encrypted? Because you better not be submitting PHI, protected health information, via an unsecured, unencrypted email to CIGNA or anybody for that matter. So how are you going to ensure that this email address and email that you're sending to CIGNA is encrypted and secure, right? So essentially, nobody's going to be mailing this documentation to CIGNA. So most of us are going to be faxing to the 800 number. Now, I'm just a small practice, but I have numerous Modifier 25 claims just today alone. Imagine you multiply that by all the providers covered that CIGNA is contracted with. Just imagine the volume of work on CIGNA's end to match the electronic claim submission and also the documentation that has come across. They now have to look at the documentation, make sure that is appropriate, and then match that claim, and then adjudicate that claim, and then remit the claim and pay you for that claim. How long do you think that's going to take? And how often will they up, right? How often will that happen? Probably a lot. So what happens then? Payment to you, the practice, is delayed. So the insurance company's job of delay, decline, deny, right? And really to defraud the providers of the appropriate payment. And also there's the concept of timely filing and appropriate timely filing that we have done. We appropriately and clearly submitted a clean claim to CIGNA, and now what they're doing is they have a lot of leeway to deny and delay payment. So there may be a claim against CIGNA regarding this timely filing. We'll see what they actually do. This additional requirement is simply going to increase the flow for the insurance company, meaning they are able to keep the premiums, more of the premiums paid by their subscribers, and often the employers of the subscribers. They can invest it, do whatever they need to do to generate more revenue. So the later they pay the providers, the physicians, the more money they generate. In addition, unfortunately, a lot of medical practices, when their claims are denied, and this is just great opportunity for CIGNA to deny your Modifier 25 claims. Unfortunately, a lot of physician practices do not appeal the denial. So guess what? More free money for CIGNA. Any sort of a hurdle that is created by the insurance companies means more revenue that is retained by these insurance companies. This is a very simple game that is being paid chronically by these insurance companies. And if you recall, about 8 months ago, not only did CIGNA do this, but Anthem, Blue Cross Blue Shield also tried to do this. United Healthcare tried to do this years ago and also tried it again last year, I think. So this is nothing new. And I have to say that when Medicare audited the use of Modifier 25 in the early 2000s, there were a lot of mistakes and a lot of misuse of Modifier 25, resulting in hundreds of millions of dollars in wrongful claims by the providers. So I understand that there are a lot of mistakes made by the providers when submitting Modifier 25 claims, but not the amazing urology folks in the Thriving Urology Practice Facebook group, because I've been talking until my face is blue regarding the appropriate use of Modifier 25 and the instances where you can use Modifier 25. Also, the painters from PRS Network has been teaching us about the appropriate use of Modifier 25. I'm a beneficiary of that education, and I've been using this appropriately with the appropriate indications, medical necessity, appropriate documentation, appropriate use of Modifier 25 for, I would say, close to 2 decades, thankfully. And if you're not using this correctly or appropriately, you're literally leaving money on the table. So make sure you know how to use it appropriately. Make sure you are playing the game by CIGNA, which will soon be followed by many other payers. And again, for those of you watching this live, feel free to leave any comments below. And also, if you're watching this on a replay, please feel free to leave the comments and I'll try to answer them as best as I can. Lastly, I want to talk about a text message or a DM sent to me by Jessica. And she said, "Hi, Dr. Lin, question for you. At the Urology Advanced Coding and Reimbursement Seminar last December, you mentioned that you took your coder into the operating room with you to observe. Had I known that was a thing, I would have asked ages ago to do it. Anyway, was there anything specific that needed to be done on the compliance end for that to happen? One of my docs doesn't think that the surgery centers would be an issue, but the hospitals might squawk. But if I have an idea what they might need, I can be ready. Thanks." Okay. What she's talking about is that I freely invite my administrative staff, the coders, the billers, the front desk, the receptionist, the insurance verification person, to my procedure room, to the operating room in the surgery center, in the hospital, to observe what actually happens in these areas, because you can be the best, you can score 100% on your CPC through AAPC or one of these other credentialing coding entities. You can recite verbatim the code, the verse, but it doesn't mean that you really understand how to apply the rules that you've just regurgitated. There's no better way than to actually see what happens in the operating room, in the procedure room, and correlate that with what you're reading when the physician documents that particular procedure. Not only that, whoever observes the procedure will now be able to tell the new patient or the potential new patient or the established patient who has been scheduled for that particular procedure what exactly happens, because he or she will have seen the performance of that procedure. So the knowledge and the understanding, the ability to apply the actual CPT codes in the real life coding situation is going to be much more enhanced when you have seen the actual procedure. And that's why I encourage my administrative staff to come into the procedure room to see how a vasectomy is done, how a cystoscopy is done, how a prostate biopsy is done, how a stent removal is done, something that we do all the time. Once you see it, you have a much better grasp of exactly what I mean when I say I'm inserting the cystourethroScope transurethral, blah, blah, blah. A lot of technical jargon. Now it makes a lot more sense for the coder and biller. That's why I highly encourage you, whenever possible, for the coding staff and also the front desk folks who are interested, who can stomach the actual procedure, to observe and see what actually happens. Because your level of understanding and your ability to describe what happens during that procedure to the potential patient will be much, much better if you do that. As far as jumping through hoops, it may be easier to do the observation in a surgery center because it's less bureaucratic, much more efficient, much more efficient overall, and much more cost efficient. So I digress. What you also need, it doesn't matter where you go to observe, you need to make sure you have patient consent, which is often included in the consent that the patient signs. And it would be nice to tell the patient verbally as well that, hey, I have my staff here who's going to be observing your surgery. Most patients couldn't care less. They just want to make sure they have a great outcome. And most patients are happy for the ability to educate somebody. And they know that we are all professionals, we're all bound by HIPAA, and we can't discuss the case outside of the practice environment. So getting patient consent, making sure that you have a written consent, that'll be ideal no matter where you have that done, where you're observing either in the surgery center or in the hospital. The hospital, much more bureaucratic, much more hoops to jump through. So if you want to observe certain cases that are not done in the surgery center, then you will have to jump through more hoops. You may want to call the OR nurse in charge and find out what documentation may be required before you actually get there so that you have a smooth day being able to observe. And also, I encourage you to be present or show up on a day where there are a lot of cases so that you are maximizing your time while you're in the operating room, which should be a problem because we are all super busy. There's a shortage of urologists and there's no shortage of patients. And that's why I tell my patients that my goal is to cure you. I tell my patients, I euphemistically want to get rid of you because there are more patients than I can handle, than any urologist can handle. So anyway, if you have any concerns, questions, comments, agreements, disagreements regarding Modifier 25 use in the case of BPH and cystoscopy, or you have any comments regarding the CIGNA's use of Modifier, the additional documentation required for Modifier 25, please let me know in the comments. I would love to hear from you. And as always, with any questions, comments, leave them below. Thank you so much for the privilege of your time. Take care of yourself and take care of each other. Hope you had a great Monday. Bye-bye.